Okay, we're going to start in on the upper respiratory system, and I'm going to start out with chapters 20 and 21. I'm going to combine those into one lecture. Most of this should be review. You should remember a lot of this stuff from assessment. And then we'll talk a little bit about some of the respiratory modalities that you're going to be encountering when you're taking care of your patients. We'll talk about that in chapter 21. And then the rest of this week is going to be in chapter 22, when we're going to start talking about the upper respiratory diseases. But I'll do that one in a separate lecture, just so these lectures don't get so long. So let's start with chapter 21 or chapter 20. A couple things I just wanted to point out, and like I said, this is probably going to be a review, so I'm sorry if this is boring, just skip by it. It is really, really important that you are able to do a really good respiratory assessment on your patient. So there's a couple things I want to point out, because you're going to have to describe this in your nursing notes. So you need to understand words like crackles, rales, rhonchi, stridor, wheezing, that sort of stuff. It's really important to understand when you hear those sounds, and if you're not familiar with them, we've got some audio in the skills lab and in the library that you can listen to what these sounds like. Typically, there's different kinds of sounds based on what your patient is going through. So if your patient has airway constriction, and when I say that, I mean right here. So this is a diagram of the lungs, and this is the bronchial tree. When this gets narrowed like this, it becomes constricted, and it could be constricted for a variety of reasons. Your asthmatic patients have this bronchial constriction a lot, but it can also be caused by inflammation. Patients with bronchitis and stuff, if the airways get inflamed, it's also going to cause bronchial constriction. When air goes through constricted airways, you're going to hear wheezing, especially down here in the lower lungs, and especially on expiration. So when your patient is breathing out, you'll hear that wheezing sound in your asthmatic patients. If you hear wheezing on the way in, it's usually from bronchitis, from inflammation. In both cases, the patient needs a bronchodilator. This is when you start putting your patient on your inhaled bronchodilators, albuterol and things like that I'm sure you're studying in pharm. That will dilate the bronchioles and allow the airway to move through there better, and hence reduce the wheezing or the stridor. Stridor is just a worse case of wheezing, and it's up higher in the airways. The higher the worse, because now if you have constricted airways way up here, now none of these airways down here are getting airflow. But if you have, let's say you just have some inflammation and some constriction down here, well, then all of this stuff is still getting good air, and that's less of a problem. Either way, you need to treat it with bronchodilators. But then if you have wet lungs for whatever reason, COPD, pneumonia, ARDS, all those kinds of things, you're going to start getting some fluid in the alveoli down in here. And that's when you're going to start hearing rales and crackles. Rales is usually a combination of airway obstruction and fluid. Crackles is usually the alveoli collapsing and not opening like it should be because there's too much fluid in there. So that's when you're going to start hearing your rales and crackling. When you start hearing that, and usually you hear the rales in the lower lobes, this happens sometimes with atelectasis. Atelectasis is the word for fluid in the alveoli. Never underestimate the power of using an incentive spirometer. That's that machine where you have your patient suck into it, and then the little balls come up to the top. And this is the machine that usually sits on a patient's bedside table, and nobody ever knows what to do with it, and then the nurse just checks off that they've done it, but they haven't actually seen it. Never, ever underestimate how important it is to have your patient using that incentive spirometer 10 times every hour, or every time you go in the room, or encourage your patient, even if I'm not here, use this, every 10 minutes. So they put the machine in, they suck it in really hard to get those balls up. And what that does is when you're sucking a lot of air in, it expands these alveoli, opens them up, and it will prevent atelectasis, which then can prevent pneumonia and worsening complications if you can keep those alveoli open. So incentive spirometer, highly underused, super effective. So I want all of you, when you graduate, make sure that your patients are using their incentive spirometers. Patients who are post-operative and they have a lot of pain, they don't want to breathe deep. It hurts. So make sure you're treating them with pain first, teaching them how to splint so they're not opening up that incision, and then taking deep breaths to prevent the atelectasis. Then they can get out of bed and start walking and prevent, because it's always about prevention. It's much easier to prevent something than actually treat it once it's occurred. So incentive spirometer, treat the pain post-operatively, very helpful. Your overweight patients, your post-operative patients, your elderly patients, as your patient ages, the entire pulmonary system becomes more rigid and fibrotic. It's like, like a garden hose. When you first buy it, it's really malleable and malleable. That's how little kids' lungs are. But the older it gets, that hose, the older the hose gets, how then it gets really rigid and hard, and it's harder to fold up. That's what happens in the lungs as a person ages. So it's really important to keep those lungs really healthy, and you do that through exercise, because when you exercise, you automatically expand those lungs and take deep breaths. So if your patient can get up even walking, absolutely no smoking. Smoking is the #1 cause of airway problems. What happens is all along your pulmonary tract, you have little cilia, little hairs that help prevent particles from getting in and help expectorate things out. Smoking gets these all dirty, so your natural filter system can't work. So these are very become dirty in smokers. Also, smokers have a decreased lung capacity. They have more difficulty getting air out. And so the smoking puts a patient at very high risk for all kinds of pulmonary diseases. So if your patient smokes, you really need to work very hard to get them on a smoking cessation program. I'm also a huge firm believer in modeling good behavior. So I can't stand to see nurses smoke. You know the problem, you know what it causes. So why a nurse would ever continue to smoke, I don't know. If you smoke, don't let me find out. It's horrible. It's horrible, horrible, horrible habit, and creates all kinds of destruction. Leads to tons of complications, which we're going to talk about over in the next couple of weeks. So I do want you to know that. A couple other things that I want you to know about as we're talking about the upper respiratory system is your sinuses, which are up here in your face. You've got sinuses up here, you've got sinuses here. They drain back into the respiratory system up here. This is your nose. So lots of times a patient who just gets rhinitis, meaning like a little common cold in their nose, it can end up becoming rhinosinusitis because the sinuses and the nasal passages are continuous. So you do need to be a little bit careful for that. If your patient starts developing sinusitis, where they get a lot of pressure, like if you put here and it hurts and they get a lot of headaches, you can put them on an antihistamine. An antihistamine is kind of like a bronchodilator for the sinuses. It'll dilate the sinuses. So things like Sudafed, Claritin, those kinds of medications help open up these passages, and they're antihistamines, because what happens is typically if your patient's having an allergic reaction or allergies to something seasonal, what happens is these passages up here, they start getting congested, which makes it difficult to breathe. It's very uncomfortable, and it's a trigger because of a histamine release. So you want that if it's a histamine release, because you're trying to prevent your body's trying to fight off whatever foreign agent is irritating it. But if you give your patient an antihistamine, it blocks the histamine release. This is histamine, blocks it, and then so there's no histamine in here, and so this opens up. Another thing that you can do, which is very helpful in your patients with rhinitis or rhinosinusitis, is nasal sprays, because those go right to the trigger. Whereas if you're taking an oral antihistamine, it affects your entire body. But the nasal sprays have like a dilating effect up into the nares and in the sinuses, and it's wonderful for relief. The thing with that is you need to be careful that it's only temporary. Somebody should only use a nasal spray for maybe a couple days. If the symptoms haven't resolved after that, they really need to switch to something maybe oral, or they, you know, if it's bacterial, need an antibiotic or something else. The problem is people can get rebound inflammation if they use those nasal sprays for too long, and they can be addicting, so that's kind of a problem. And then they keep using the nasal sprays, and then the inflammation gets significantly worse over time. So you do need to be a little bit cautious with the nasal sprays. The other thing that I want you to know about is I want you to know about the chart 2020, and this is called a VQ scan. Let me find where it is. Yeah, on page 469. I want you to understand the normal flow of oxygen and carbon dioxide in and out of the alveoli system. It is important that you have an adequate exchange of oxygen and carbon dioxide, and there's a scan called a VQ scan. It stands for ventilation perfusion. Why it's a Q instead of a P, I don't know. But there's, if you suspect that your patient is having a problem with proper oxygen carbon dioxide exchange, your patient can go for a VQ scan and actually determine if that exchange is appropriate. The other things, I do want you to know how to do a good pulmonary assessment. So look at, this is going to be starting on page 472. I want you to understand some of the words in here and some of the things that you would do when you're getting a good pulmonary assessment on your patient. I want to point out there is a difference between being hypoxic and hypoxemia. It's kind of, you know, 6 of one, half a dozen of the other, but you do need to know this so you don't sound like an idiot when you're talking to a physician. But hypoxia is inadequate oxygen at the tissue levels. Hypoxemia is inadequate oxygen levels in the bloodstream. Obviously, if you have inadequate oxygen levels in the arterial system, it's going to lead to hypoxia, but I just wanted to point out those real subtle differences just so you sound brilliant when you're talking to somebody in the pulmonary system, when you're working on your pulmonary units. A couple of things, the major disorders that we're going to talk about are asthma, and that's an narrowing in the airways, COPD, chronic obstructive pulmonary disease, we're going to talk about that when we're talking about the chronic diseases, emphysema, bronchitis, cystic fibrosis. Cystic fibrosis is a major lung disease that is genetically driven. People are born with cystic fibrosis, like they're genetically predisposed to cystic fibrosis. So we're going to talk about that. That's a little bit of a, it's a sad disease. That one, the cystic fibrosis, they develop copious amounts of mucus in their lungs, way too much, because you're supposed to have some mucus to help get rid of infiltrates and things like that. But too much mucus is not a good thing. And that's what happens in cystic fibrosis, but we'll talk about that in more detail later. The other thing I do want to point out, because this is a good finding, is flip over to page 475 and see that clubbed finger thing. If you start assessing, you're doing an assessment on your patient and you're noticing that they're having clubbed fingers, meaning, you know, the nail bed, there's a good picture of it on 475. That is almost always an indication that your patient has a lung problem. So if you start seeing that's an indication of long-term hypoxia, and most of the time that's because they have a lung disorder. So if you see that, you might have to do some additional studies to find out what's up. Another thing that you want to do is when you're assessing your patient, so you stand back and you're watching their ventilation, and you do need to understand tachypnea, bradypnea, the normal like Cheyne-Stokes breathing. I do want you to, and that's in your assessment chapter here. But there's something called the use of accessory muscles. When a person normally breathes, your nerves innervate the diaphragm, and that comes out of C4. We'll talk about that in the neuro section next semester. So you've got this nerve that comes out of C4, and it innervates the diaphragm. And in most people, not COPD patients, your brain initiates when your CO2 levels are getting too high. It triggers a sensation in your brain, and you take a breath. And that nerve goes down to your diaphragm, and the diaphragm pulls down, and air rushes in. That's how normal respirations work. carbon dioxide gets too high, triggers the brain. The nerve impulses go to the diaphragm. The diaphragm pulls down, and air, because of now I've created negative pressure in here, air rushes in. And then just by relaxing, exhalation occurs, the diaphragm relaxes, and carbon dioxide is excreted. So that's how a normal person works. If somebody becomes in respiratory distress, and this is, you can see this in little children, they'll start using accessory muscles, meaning muscles that you don't usually use to take a breath. And that could be the intercostal muscles, because you don't really need your intercostal muscles, the muscles between your ribs. You don't need that to breathe. But sometimes if somebody's in distress, you'll see these muscles starting to contract in here. And you'll see their abdomen starting to work really hard, like they'll pull it trying to pull that diaphragm down. Or they'll push it out with their abdominal muscles. That's called accessory uses, and that means your patient's probably developing dyspnea and having some trouble breathing. So watch for things called the use of accessory muscles. Another thing that you're going to want to do when you are assessing your patient, especially if they have lung problems, is percussion. And when you're doing percussion on a patient, I'm sure you learned this in skills or assessment, you cup your hands like this, and then you just kind of clap it like over somebody's chest like that, and you can hear different lung sounds. And if you get to a spot that's dull, the patient probably has fluid in there. Another thing that you can do is called P&PD, percussion and postural drainage. So let's say that your patient has a pneumonia in like an upper lung. You can lay your patient down and use gravity, like put a pillow under here so this lobe is down. That's called postural drainage. You're trying to drain the fluid you want to get the fluid, like let's say you have fluid up here and you want to get it into an airway. So you might lean this patient forward, you might lean a bit, depends on like where this spot is. If you've got a spot down here, you're going to want this lung up. Wherever the fluid is, you want it up to use gravity to drain into the airway. And then what you would do is you would position your patient, that's called postural drainage, and then you put percussion right over that. And the theory is that it breaks up the mucus into smaller pieces. You get it down into the ciliary so the patient can expectorate it. That's called P&PD. The other thing I wanted to point out when you're doing an assessment, and this is important to remember for all of your patients, it is important when you're trying to diagnose what's wrong with your patient is you start little and move up. So the first thing that you're going to do, like let's say that your patient is having some coughing, maybe some use of accessory muscles, maybe has a fever. So now you have to try to figure out what's going on with my patient. The first thing that you would do after you get a fever and like you'd listen to the lungs, you find out, okay, maybe I've got rales and crackles, I've got my temperature's a little bit elevated. So now you're starting to think, do I have a bronchitis? Do I have a pneumonia? What's going on with my patient? So step one, easy peasy, vital signs, fever, temperature. Okay, now I'm still suspecting I might have something going on. So now I'm going to go draw some labs. Do I have an elevated white blood cell count? And let's say it's elevated. So now I'm thinking, okay, it's probably not a malignancy because that wouldn't elevate your white blood cell count, nor would that cause a fever, but it could still lead to a pneumonia. So now what? Now I'm going to go get a chest x-ray, because on chest x-ray it's going to show me if I have some fluid in there. And you can tell on chest x-ray if it's a fluid or if it's a mass. They look different. And I'll show you some pictures in class of what some of those look like. And so then you can pretty well determine I have a fever, I have some fluid here, my white blood cell counts are elevated, I can hear some rales and crackles, my patient probably has a pneumonia. Next step, I'm going to start some antibiotics. And then some things like incentive spirometer, getting up, walking around, things like that. If you find out that it's a mass, if the x-ray says, look, it looks like a white solid mass there, now I'm thinking, maybe I have something different. So then this next step after that is to get a piece of the tissue. You never ever actually know what it is unless you get a piece of a tissue, meaning your pathology. You've got to get a biopsy and get a pathology. The pathology will take that piece of tissue to the lab, and they can identify in the lab what is it. Is 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 there an abscess here? Is it a tumor here? What do I have going on? But you can't fully identify that until you actually get a piece of it, and that's called a biopsy. That's true with any tumor in anything in the entire body. You can't confirm it until you get a biopsy. If there's something there that you identify on an X-ray or CT scan or an MRI or an ultrasound. So you do need to understand, like a CT scan, there's a CT scan regular and a CT scan with contrast. If your patient gets a CT scan with contrast, they put an IV in and they inject dye, and then the dye usually lights up whatever you're trying to look at a little bit better. The thing is, with the IV, now this dye is going to go everywhere. It's not selective to just whatever it is you're looking at. It's going to go everywhere in the body. The problem with that is it gets excreted through the kidneys. The dye gets excreted through the kidneys. So you need to make sure that your patient's kidneys are functioning and that they don't have an allergy to shellfish. Because the allergy to shellfish, and by shellfish I mean shrimp, lobster, crab, any kind of thing in the ocean that has a hard shell on it is a shellfish. If they have an allergy to that, like if they tell you, well, I've been eating shrimp and then I get hives, they have an allergy to that. And the dye that they put in here is made out of the same stuff that shrimp and lobster, now I just lost my word, crustaceans or whatever they're called. It's made out of the same stuff, so you can't use contrast on somebody who has an allergy to that, unless it's really mild and you absolutely have to have it. Then you've got to treat them with a whole bunch of steroids and watch them really close and make sure you got a vent just in case they anaphylaxis, stuff like that. Okay, so you know what I'm gonna close this tape off here just so it's not too terribly long, and then I'll do chapter 21. We'll talk about respiratory modalities in the next one. I said I was going to combine them, but it gets too long, and that way you can have a break. All right, so I think that's it. Let me just make sure that I told you everything I wanted to in chapter 20. Barrel chest on page 476, barrel chest, we're going to go over that a little bit more in COPD. That's just when the chest gets really round. Do know table 25, the different breath sounds. The reason is you'll see these in charts and stuff, and it's important for you to know if they're talking about vesicular breath sounds or bronchial breath sounds or tracheal breath sounds. Vital capacity, this is important. Forgot to tell you about this. I'm over on page 483. You do need to know, because we're going to talk about this when I'm going to tell you about respiratory modalities, you do need to understand the words like tidal volume, meaning that is how much air is inspired with each breath. That's called your tidal volume. Vital capacity is how much actual oxygen you can hold. Your vital capacity is just kind of like your regular breaths, and that's anywhere between 4 and 1,000 milliliters. But your vital capacity is how much, like if you take an extra breath, like you breathe regular and then keep extending, take a huge deep breath, that's your vital capacity. So some of those I do want you to know. Forced or peak flow meter is, you'll see this a lot because everybody and their brother has asthma, and a peak flow meter is something that asthmatics will use, and they go like that, and then there's like a, I think I might have one. I'll have to show you. And there's a little button that goes up and down on it, so you can tell when an asthmatic, they take a breath and then they go blow out really, really hard, because in a patient who's having an asthma attack, these get congested and it's really hard to expel air. So a peak flow meter will give you a pretty good indication of how bad your asthmatic patient is. So usually your asthmatic patients will keep a chart of if they red, yellow, or green, and then you can tell how bad that asthma is and if you need to increase their medications or double up on the bronchodilators or something like that. So make sure that you're understanding that. The bronchoscopies, that's just like I was telling you, if you need to go down and get a piece of a mass, your patient would go for a bronchoscopy. You have to sedate your patient because you're putting something right through their trachea. Nobody loves that. This right here, when the airway comes down and branches. This is called the angle of Lewis, and you've got a very, very strong cough reflex right here. So this is why when you suction your patient, you're suctioning down the trachea. If you hit that right there, that's when they start coughing. Not that that's a bad thing, because when your patient coughs, this constricts and it forces expectorant and stuff out. So that's not bad, but the angle of Lewis or the carina, those are both the same thing, and that's where your cough reflex is right there. That's why your patient coughs when you're suctioning them. A centesis, go over to page 489. Sometimes your patient can have fluid almost on the outside, because you have a pleural cavity here, and this is filled up with fluid. Sometimes this will start pushing the lung in like that. Sometimes it can be on the inside of the lung too. You start developing a fluid collection in there, and you can do something called a thoracentesis, where, I mean, you know, but you would assist with it, where they put a large needle in, and you set the patient up, because again, you want to use gravity. You put a needle in and you just pull out fluid. Anytime you see that word centesis, that means to pull out fluid. You can have a pericardial centesis when you get fluid around the heart. You can have an abdominal centesis when your liver patients have ascites and they start getting too much fluid in the abdominal cavity. So centesis is that word for removal of fluid. So in your lung patients, you can have a pleural centesis, meaning actually pulling out fluid using a big syringe. And you would assist with that as a nurse. Okay. All right, so that's it. I'm going to quit here, and then we'll come back and start in on Chapter 21, respiratory modalities. Okay.